I want to welcome everybody to our worldwide edition of the case competition. Today we have, let me see how many. So we are going to hear from
25.
25 different cases, but they are from Asia. We have people from Africa, from the Americas. So it's truly a global case competition. The cases are amazing. Just like the images that we are producing all around the world are just stunning, and the breadth of the areas that are or the kind of cases that we are able to help with through radiology are also amazing. So we're gonna again thank our departments and the leadership in our departments at the Children's Hospital of Philadelphia, and at the Department of Radiology of Penn Medicine, our adult partners, and of course the Center for Global Health at the University of Pennsylvania. So today, again, we're going to have a special format. We have more cases than in previous iterations of the case competition. And we're going to try to go through them in blocks, giving you a little intermission in between. And of course, after or immediately after we see all cases, we'll announce who the winners are, and let you also vote for whatever the audience think is the best case. I think that, again, given that it's past 9:05, that is kind of at the time that we wanted to start showing the cases, I'm gonna pass it on to Mohammed and Sydney that are in Philadelphia, like in the control room, like just to start introducing the cases and get us started. Thank you guys for being here.
Thanks, Hansel. Hope you're enjoying Mexico. So just to add to what Hansel just said, this competition also features a new section, which is a poster section. So we had selected abstracts for oral presentations and abstracts for poster presentations. Both were equally interesting and had amazing images, but for the sake of time, we had to split between posters and oral presentations. So you can access the list of posters through this QR code, and I will be posting it in the chat in a bit. You can surf through them, check them out. They're very interesting. They have very nice images. And importantly, by the end of the session, I will be sharing another QR code for you to vote for the posters. I will be giving more information about this during the session. Okay, so without further delay, I want to kick us off with a case from Brazil. Dr. Tiago de Coltier Paulo will be discussing a case of disseminated cysticercosis with cardiac involvement.
Hello, everyone. Thanks for the opportunity to speak today. My name is Thiago de Gautier, and I'm from Universidade de São Paulo, Brazil. Today, I represented a case of disseminated cysticercosis with cardiac involvement. We have no disclosure. This case involved a 50-year-old man with a history of neurocysticercosis who required the placement of a ventricular peritoneal shunt. He had no other comorbidities and reported close contact with animals and poor sanitation conditions. Patients present to the emergency department with seizures, alacranial headache, vomiting, agitation, strabism of the right eye. He was referred for imaging and CT scan of the head. The head CT scan showed evidence of hydrocephalus with CSF transudation on the head arrows. Additionally, there are calcified nodules through the brain on the yellow arrows. Due to suspected catheter obstruction, X-ray and CT scan of the abdomen and chest was performed. The chest X-ray shows multiple rice grain-shaped calcifications diffusely spread throughout the subcutaneous tissues, consistent with muscular cysticercosis on the yellow arrows. Additionally, there is a right-sided ventricular peritoneal shunt catheter on the green arrow. The chest CT shows multiple well-defined calcified lesions diffusely spread throughout the subcutaneous and myofascial tissues. Additionally, nodular calcifications are observed in myocardium. Following the confirmation of the findings in the diagnosis of ventricular peritoneal shunt malfunction, the patient received an EVP shunt, leading to resolution of the symptoms. On the right, a follow-up cranial CT scan demonstrated resolution of hydrocephalus with persistent nodular calcifications spread throughout the cerebral parenchyma. Cysticercosis is an endemic disease in many developing countries due to poor socioeconomic development and domestic pig raising. It can affect any organ, but the most common sites of involvement are the central nervous system, eyes, and muscles. Neurocysticercosis is a common neurological disorder. Almost any neurological symptom has been reported, with epilepsy and headache being the most common, followed by those caused by CSF obstruction. Cardiovascular involvement can occur in up to 25% of disseminated cases, with symptoms range from asymptomatic to chest pain, arrhythmias, pericardial effusion, and involvement. While disseminated cysticercosis is a rare form, it's recommended to investigate other organs when multiple neurocysts are present on the brain CT scan. Patients should be educated on preventive measures to avoid recontamination, consequently minimizing the risk of future events. Thank you. Hello, everyone.
That was an interesting presentation of cysticercosis and the representation as well. Moving to the next presentation, it is from Dr. Valepu Krishna Priya from India, talking to us about a rare case of spontaneous idiopathic intramural hematoma of the colon. Let's hear what we have.
Hello everyone, myself Dr. V. Krishnapriya, final year radiology resident from Maharaja Institute of Medical Sciences, Andhra Pradesh, India. Today I am here to present a rare case of spontaneous idiopathic intramural hematoma of colon under the guidance of Professor Dr. C.H. Mathri. This is a case of 30-year-old male patient who was normally built under daily wage labor by occupation who came to emergency department with the chief complaints of lower abdominal pain and constipation since 4 days associated with 4 episodes of vomitings. The patient had history of 2 episodes of melena 5 days ago. On clinical examination, tenderness was elicited over lower abdomen of the patient. Patient was advised radiological and laboratory investigations. Laboratory findings. Serial CBC counts revealed a fall in hemoglobin counts from 11.8 grams on day 1, which were done outside our institute, to 7.6 grams on day 6, which were done in our institute. Serial albumin and total proteins were low. Bleeding time, clotting time, and prothrombin time were in normal limits. There is an X-ray erect abdomen which is showing multiple air fluid levels in the central abdomen along with a dilated descending colon with air fluid level, and my provisional diagnosis based on this X-ray was large intestinal obstruction. And on ultrasound abdomen, there is a large, well-defined, heterogeneously hypoechoic lesion in the sigmoid colon with no internal vascularity, and on color Doppler examination, there is mild amount of heteroechoic fluid with internal septations noted in the peritoneal cavity, and on USG-guided aspiration revealed hemoperitoneum. These are the coronal reconstructed images of CECT abdomen, which are showing a large, well-defined iso to hypodense lesion of size 10 centimeters noted in the distal sigmoid colon, and proximal rectum. And on contrast administration, the lesion is showing no enhancement, which is causing near complete luminal narrowing, leading to acute large bowel obstruction. And my provisional diagnosis is acute intramural hematoma with perforation of the bowel wall causing hemoperitoneum. And the intraoperative findings include colorectal intramural hematoma with serosal perforation causing hemoperitoneum. On HPE, the specimen from the sigmoid colon and proximal rectum reveal large areas of hemorrhage with inflammatory tissue in submucosa and areas of hematoma formation. Intramural hematoma of gastrointestinal tract is an uncommon occurrence, with the majority being localized to the small bowel. Intramural hematomas in colon and rectum are very rare. The exact incidence of colonic intramural hematoma is not well documented in the medical literature, largely due to its rarity. The causes range from trauma to spontaneous onset. Our patient is unique in that no pathology or non predisposing factors were present. It was a truly spontaneous intramural hemorrhage par excellence. Patients present usually with abdominal pain, intestinal obstruction, or an acute abdomen. Risk factors include trauma, anticoagulation drugs, hemophilia, idiopathic thrombocytopenic purpura, leukemia, lymphoma, myeloma, chemotherapy, and vasculitis. Advances in cross-sectional imaging, primarily CT, have contributed to the early and accurate recognition of this condition. Unenhanced CT findings have been reported previously and include homogeneous and symmetric intramural thickening with hyperdense material of HU 30 to 80 in the bowel wall. Prompt and early recognition of non-traumatic spontaneous intramural hematoma by the radiologist is a crucial contribution to the patient treatment that may prevent unnecessary exploratory surgery. Postoperative imaging. A follow-up abdominal imaging study such as CT scan may be performed to ensure complete resolution of the hematoma and to check for any residual or new issues. On follow-up of my patient, which was done using CT scan, the patient showed no residual lesions in the bowel, and now the patient was leading a normal, healthy life. Thank you for this wonderful opportunity. Have a nice day.
Very interesting case from Dr. Priya. Moving to the third presentation of today, Dr. Lizzie Peswa from Botswana will be discussing a case of disseminated tuberculosis in a 10-year-old immunocompetent child.
Good day, everyone. My name is Dr. Lizzie Peswa. I'm a second-year pediatric resident at the University of Botswana, currently based in Princess Marina Hospital. Today, I'll be sharing with you a unique case of disseminated tuberculosis, which in a child, which even though we're in a TB endemic area, was quite interesting to see, given that our patient was HIV negative with such extensive disease. So my two mentors for this case were Dr. Rachel Martin-Blaze, who's an associate professor and pediatric infectious disease specialist, as well as Dr. Tutora Lehoreng, who's a pediatrician currently working with us in our PIDS unit in Princess Marina Hospital. Before I go any further, I'd like to add that written consent was obtained from the patient's guardian to further discuss this case in the medical community. So the case we had was that of a 10-year-old boy, HIV negative, who attends an all-boys boarding school in Zimbabwe. He was initially referred to our facility with suspicion of a malignant testicular mass. Otherwise, he had had progressive deterioration of his health over a 1-year period that was marked by a tender right scrotal mass with dysuria as well as pyuria. He also had persistent fever, generalized body weakness, unintentional weight loss, and a chronic right ear discharge. On review, his medical records revealed recurrent urinary tract infections that were not responding to conventional antibiotic therapy. And urine samples collected on all these occasions had yielded sterile pyuria as well as negative cultures. So on physical examination, this was a patient who was emaciated at the time, was in obvious pain distress, as well as having fevers with BPs plotting above the 95th percentile for age and height. He had multiple cervical, inguinal, and submandibular lymphadenopathy with a scrofula that was also noted on the right submandibular area. He had a purulent discharge from the right ear with no clinical evidence of mastoiditis. Of note, he had profound hearing loss on this ear as well. His abdominal and genital examination revealed tenderness on the suprapubic areas as well as the right flank with a tender right scrotal swelling and pus that was noted at the urethral meatus. Otherwise, there was no significant findings on respiratory and cardiovascular examination for this child. So the investigations we did for this patient was a contrasted computer tomography to investigate further for all these systems involved. The first image that we're seeing here is a CT chest with coronal views of the lungs, showing multiple apical cavitary lesions that are denoted by the red arrows as shown there. This patient also had multiple small and distinctly marginated nodules that were seen throughout all the lung fields. So this is a patient that had clinically silent but radiologically evident lung disease. The next three images will be depicting the urogenital system. So the first image that we have here is showing the right kidney with a complex cystic mass that communicates with the right collecting system. As we can see with the arrows, what the arrows are pointing at there. Then here we also had still with the urinary tract from the kidney, we could see here on the right side that we have a diffusely thickened and enhanced right ureter, as well as what we noted to be 29 by 20 millimeter cystic mass with ring enhancing irregular walls that occupied the entire prostate, which was suspicious for a prostatic abscess, which in literature, when you go through it, will tell you that prostatic abscesses are predominantly usually either found at autopsy or in very elderly HIV positive males. Then this image here is a sagittal image, still a CT image showing the urinary bladder, which was also quite diffusely thickened and hyper-enhanced with decreased bladder volume. We also did a CT brain for the patient to evaluate the right middle ear structures given the hearing loss, as well as to see if there's any intracranial extension of the tuberculosis in the form of tuberculomas. So the images that we have here otherwise showed no intracranial involvement, but they did show severe right otomastoiditis with destruction of the ossicles, which clinically we were seeing as the hearing loss that I've mentioned in this patient. We're normally supposed to be seeing in the mastoid air cells, but here we can see that we're not seeing that, and there's a lot of sclerosis in that patient. So in terms of our laboratory findings, the urine studies here were showing the sterile pyuria that I've already mentioned. He had also done a testicular ultrasound that had shown a hypoechoic and markedly enlarged epididymis. Otherwise, his workup had shown Mycobacterium tuberculosis that was detected on both the urine culture as well as the induced sputum gene expert. So in conclusion, we made a diagnosis of disseminated TB. We had cavitary pulmonary TB, urogenital TB, TB lymphadenitis, as well as tuberculous otitis media. So this was a patient that was started on antituberculous treatment at the time, as well as pyridoxine and oral prednisone. The patient had continued to improve clinically during the stay in the hospital, and was a patient that we're going to be following up with nephrology, urology, as well as pulmonology and ENT, so that we can also see how he has responded and what the spectrum of disease sequelae will be at that point. So this case demonstrated the importance of imaging studies in diagnostics, as well as having a high index of clinical suspicion in children with non-resolving symptoms from TB endemic areas. That is all I had for you today. Thank you.
Thank you, Dr. Peswa, for this very interesting case, very thorough discussion, and very nice images as well. Moving to the fourth presentation, I would like to just remind you that you can access the posters in the chat through the link that we posted. Check them out. They are very interesting and very educational. So the fourth presentation for tonight from Vietnam, Dr. Thi Hao Nguyen, will be presenting a case of mesenchymal chondrosarcoma originating from the femoral vein mimicking deep venous thrombosis.
Hi everyone, my name is Thi Hao Nguyen from Hà Nội Medical University in Vietnam. Today, I would like to present a case of mesenchymal chondrosarcoma originating from the femoral vein mimics deep venous thrombosis, a first ultra-rare tumor with ultrasound images. Here we have a 32-year-old man who came to a hospital with 1 month of discomfort in lower medial left thigh when running. He denied any pain, redness, wound, or swelling. He did not have any remarkable medical history. On the smaller part ultrasound, as you can see in this picture, there was a hyperechoic thrombosis with calcification inside the femoral vein, which completely plugged the drain. The lesion also caused the vein dilated to 21 millimeter inside. So on the vascular ultrasound combined with Doppler, there was a giant local dilation with vascular signal inside. So at this image, the radiologist thought that it might be a thrombosis or might be a vascular originating lesion. So they suggest need to have the MRI to investigate more. On MRI, the lesion was well defined with the intermediate signal on T1 rated and high signal on T2 rated, which were not shown here. After the contrast, the mass was strongly enhanced and encased a third fold secure of the femoral artery and completely encased the femoral vein. So after MRI, the radiologist thought that it might be schwannoma or vascular originated leiomyoma. However, the patient was treated at different thrombosis with anticoagulated medicine. He did not get any symptom improvement after 1 month, so he decided to go to my hospital. The physicians decided to perform surgery for him. So after that, the pathology results showed it was mesenchymal chondrosarcoma originating from the femoral vein. The mesenchymal chondrosarcoma actually is an ultra-rare sarcoma. From SEER data in the US for 40 years, they just get more than 200 cases, and from ACRS in Australia for 21 years, there were 22 cases which were reported. The sarcoma can be met in skeletal or extraskeletal location. It has the very typical characteristic on image with calcification inside the mass. However, for our base of the knowledge that there were no prior ultrasound images of the mesenchymal chondrosarcoma in the femoral vein was reported. Therefore, although rare, always consider the possibility that an endoluminal lesion could be a neoplasm, particularly in the absence of the risk factors for deep vein thrombosis. Here is my references. Thank you so much.
What a very rare case from Vietnam. Thanks for sharing this with us. Moving to the fifth presentation, it's Dr. Burhan Zafar from Pakistan. Will be talking to us about a unique case of iatrogenic vertebral artery pseudoaneurysm and vertebrosigmoid fistula. Let's check it out.
Hello and good morning. I am Dr. Burhan Zafar, Fellow Vascular and Interventional Radiology at Aga Khan University Hospital, Karachi, Pakistan. My mentor for today's presentation is Dr. Tanveer Haq. He is neuroendovascular and vascular interventional radiologist at our hospital. He is also the program director of Vascular Interventional Radiology Fellowship Program here at Aga Khan University Hospital. My team member is Dr. Fatma Bujani. She is year 4 resident of radiology at our hospital. Today, I'll be presenting a unique and rare case of interventional neuroradiological management of iatrogenic vertebral artery pseudoaneurysm and vertebrosigmoid fistula following retrosigmoid craniotomy of vestibular schwannoma. A 43-year-old gentleman presented to our OPD with complaints of vertigo, headache, and right-sided hearing loss for 2 months. Neurological examination revealed intact higher mental functions, including speech and memory. MRI brain was performed, which revealed a right cerebellopontine angle lesion consistent with vestibular schwannoma. These are the limited MR images of The patient, we can see that there is this large lesion lying within right cerebellopontine angle, resulting in mass effect over the brainstem and right cerebellum. It is appearing hyperintense on T2, hypointense on T1. Weighted images is showing post-contrast enhancement, peripheral post-contrast enhancement on T1 weighted images. It is the beak of this lesion is in close approximation to the hypoglossal canal and is not showing diffusion restriction. So overall, these findings represent a vestibular schwannoma. The patient subsequently underwent right retrosigmoid craniotomy and resection of the lesion. Patient presented again on 10th post-op day with complaints of drowsiness and seizure-like episode in our ER. Patient was admitted and unenhanced CT brain was performed, which showed a craniotomy site resolving hematoma, acute infarcts in bilateral occipital lobes, left parietal lobe, bilateral cerebellar hemispheres, and left basal ganglia. MRI examination after admission was performed, which shows a large pseudoaneurysm arising from the V4 segment of the vertebral artery. This hypointensity within this pseudoaneurysm is a jet phenomena. This pseudoaneurysm is in turn draining into the right internal jugular vein via the sigmoid sinus. Subsequently, CT angiogram was performed to better delineate the arterial anatomy. We can see that this is V4 segment of the right vertebral artery, and this large pouch representing pseudoaneurysm is filling from the right vertebral artery. Patient was subsequently shifted to our interventional radiology suite, and we performed a diagnostic cerebral angiogram via right vertebral artery. We can see that this is site of leak from the right vertebral artery, and this large pouch is filling from the right vertebral artery and is representing a large pseudoaneurysm. This pseudoaneurysm is in turn draining into the sigmoid sinus, and via sigmoid sinus it is draining into the jugular vein. Jugular vein is quite apparent on arterial phase images. So this was representing a large pseudoaneurysm with sigmoid fistula, vertebrosigmoid fistula. We plan to place a covered stent across this pseudoaneurysm in order to obscure the fistula, in order to occlude the fistula, and to cover the site of leak. After the placement of covered stent, we can see that there is adequate flow into the posterior circulation. Previously, this fistula was draining almost all of the blood, and no filling of the posterior circulation was noted. So pseudoaneurysm and arteriovenous fistula is a rare iatrogenic complication after retrosigmoid craniotomy. It is very important to diagnose such lesions as early as possible, as the stasis of blood within pseudoaneurysm results in distal embolic phenomena with resultant infarcts, as seen in our case. Over time, the treatment of such lesions has evolved from surgical approaches to endovascular stenting techniques. So one should always be cognizant of these lesions. This is a rare case of vertebral artery pseudoaneurysm and vertebrosigmoid fistula that was successfully treated with endovascular stenting. And there is importance of timely diagnosis because these lesions can result in embolic phenomena via advanced imaging, and minimally invasive interventions can reduce morbidity in such lesions. These are my references. Thank you.
Thank you, Dr. Zafar. Showed us the importance of accurate and timely diagnosis in medicine, especially in this vascular pathology. Moving to the sixth presentation from Dr. Elsa Wartono from Indonesia, who will be talking about a challenging case of congenital bronchoabdominal fistula.
Greetings, everyone. My name is Austin, and I am a R4 radiology resident from Faculty of Medicine, Universitas Indonesia. Today, I would like to present our challenging case of congenital bronchoabdominal fistula, from the diagnosis approach to management, on behalf of my radiology attending, Dr. Ido, Dr. Yani, and Dr. Gita, and also Dr. Rifan from Pediatric Respirology Department, and Dr. Hadi from Cardiothoracic Surgery Department that have contributed vastly to the diagnosis and management of this patient. Our patient is a previously healthy 3 days old neonate, which was born with the help of the traditional Indonesian birthing shaman. The patient became dyspneic and referred to our hospital for further evaluation and management. The patient experienced desaturation episode and was admitted to neonatal ICU and intubated. However, during the admission period, yellowish-green fluid were noted coming out from the endotracheal tube, and bronchoscopy referral was made to evaluate the possibility of fistula. The bronchoscopy revealed yellowish mucus coating the surface of the trachea and right bronchial tree. Excessive bubble was also noted coming out from the right middle lobe bronchus. Based off these findings, the preliminary diagnosis of bronchoesophageal fistula was made, and further evaluation using contrast meal was done. The contrast meal was done, and we did not find anything resembling fistula from the esophagus through the small bowel. So bronchoesophageal or tracheoesophageal fistula can be safely ruled out. As there was still question about the fistula's connection, chest contrast enhanced CT was done. This axial stack of contrast enhanced CT clearly showed a fistulous connection from the main bronchus, middle lobe bronchus, that extend inferiorly, passing through the right diaphragm and ending in the porta hepatis region. Curve format of the coronal and sagittal showed the whole segment of the fistula. This focus image showed the fistulous connection related to right hepatic artery, common hepatic artery, and left hepatic artery. There is also a suspected neomobilia anterior to the fistulous tract. PRT showed the fistulous connection, atelectasis of the right lung, and hyperinflation of left lung. During hospitalization, the patient still had recurrent bouts of desaturation. Moreover, there is developing progressive right atelectasis, and it was complicated by pneumonia of the left lung with positive sputum culture of Klebsiella pneumonia and Acinetobacter baumannii. The patient then underwent surgery to ligate the fistulous connection. However, the patient developed bradyarrhythmia during further exploration, and decision was made to ligate the fistula. Under day 24, bronchoscopy evaluation with direct fistulography per bronchoscopy was done and showed good patency of the ligation site distal to the fistulous remnant. Follow-up chest radiograph showed improvement in the right lung atelectasis and pneumonia. The saturation improved and the patient was extubated. The patient continued to show improvement and stepped down from the neonatal ICU. On day 33, the patient had no respiratory symptoms, good oral tolerance, and gaining weight. The patient then discharged and has visited cardiothoracic outpatient clinic without any symptoms. We report a case of congenital bronchoabdominal fistula with high probability of congenital bronchobiliary fistula. Shimizu et al. Showed yellow sputum in their case of bronchobiliary fistula compared to our yellow mucus coating to the surface of tracheobronchial tree. This yellow color is the result of unoxidized bile compared to greenish bile in upper bowel obstruction that has underwent oxidation. Our case was managed by ligation of the fistula compared to others that have reported the use of fistulectomy to manage the patient, with good outcome. Our patient had also good outcome during short-term follow-up. For conclusion, we present a case of bronchoabdominal fistula with a high probability of congenital bronchobiliary fistula that was diagnosed and monitored with multidisciplinary and multimodality approach. Management by fistula ligation resulted in good outcome during short-term follow-up. Thank you for your attention.
Thank you for
Greetings,
this
everyone.
from Indonesia. I personally like the presentation skills, the images that were shown. So moving to the 7th presentation, Dr. Yusuf Ahmed from Egypt, Ain Shams University, will be presenting a case of Currarino syndrome misdiagnosed as an infected adnexal cyst.
Hello, this is Yusuf. I'm a second year resident of DR and IR at Ain Shams University in Cairo in Egypt. And I'm definitely excited to be here and to have a nice case to show. We got a request for an abdomen and pelvis CT for a 17-year-old virgin girl. The referring surgeon provided the following data. She presented to the OBGYN ER with severe abdominal pain, rigid abdomen, fever, and an elevated TLC count. The gynecologist did a transvaginal ultrasound and they saw a large infected adnexal cyst. And they transferred her directly to the OR for an open laparatomy. They found that the adnexa to be free during the operation. They closed her up and transferred her to the general surgery department, where they ordered the CT. As we can see, the CT there is definitely a cyst. It looks infected. It's large. Could be an infected adnexal cyst. Could be not. As we look deeper, we can find, there is an enhancing wall. It's pushing the uterus forward. It's pushing the rectum. It's pushing the bladder. It's anterior to the sacrum. The patient had an X-ray for the abdomen done, and that caught our attention. There is definitely a sacral deformity here. And if we looked at this on the sagittal plane, you can see there is something that seems to be coming out of the vertebral column, seems to be connected to the fecal sac. It led us to consider a certain diagnosis. He reported the CT as follows. Right hemisacral agenesis with a large localized fluid collection, multiloculated with peripheral thick enhancing wall and internal air foci. It occupies the presacral retrorectal space with connection to the fecal sac. It measures 10 by 9.5 centimeters. This is an infected anterior presacral meningocele. We did an MRI. It showed it nicely, but we concluded that it's probably a large anterior meningocele and smaller ones as well. It's not a multiloculated one. But before the surgery team wanted to operate, they wanted a confirmatory diagnosis that would reveal a connection with the fecal sac. So we did a CT myelography that did not reveal a communication between the large cyst and the fecal sac. Only the small cysts were proved to be connected to the sac. So we started to consider another diagnosis. Guarino syndrome, it's a rare complex condition. It's usually like a triad of certain congenital anomalies, an anorectal malformation with a sacrococcygeal osseous defect that is always present. Not all the features need to be present, but a sacrococcygeal osseous defect definitely is always present. Classically a hemisacrum and presacral masses, anterior sacral meningocele, or a teratoma. This could be it. Hemisacrum, anterior sacral meningocele, plus what? It's a teratoma. We decided to consider the diagnosis of a teratoma. The neurosurgery team operated the patient and they confirmed it to be a teratoma. So what I need to focus on today is there are limitations for every diagnostic tool. An ultrasound might not be conclusive. Before taking a patient into surgery, you could consider other options. And every differential diagnosis has its own imaging tool that's specific for ruling it out. Like we did the CT myelography to confirm the communication with the fecal sac. I hope you like the case. I hope you learned something, and it was definitely a pleasure meeting you today.
Interesting case. And it was educational. Thank you, Dr. Yusuf. Now, moving to the 8th case, I would like to remind you also that by the end of the session, we would have a poll for the attendees to vote for their favorite case. And this favorite case will be the winner of the People's Choice Award. So just tune in, ask your friends to join to support you, and let's move forward. This case is from Dr. Josefina Medina from Philippines, and she will be talking to us about the dry type tuberculous peritonitis with concomitant chronic tuberculous appendicitis.
Good day, everyone. I am Dr. Josefina Medina from the Institute of Radiology of St. Luke's Medical Center, Quezon City, Philippines. I am presenting on a rare and unique case of dry type tuberculous peritonitis with concomitant chronic tuberculous appendicitis in an 18-year-old female patient. An 18-year-old female patient complained of crampy and intermittent periumbilical and epigastric pain that started 3 months prior to admission. She was initially managed as a case of gastroesophageal reflux disorder. She was noted to be weak-looking with tense abdomen and GERDing. She was born and raised in the United States and went to the Philippines for college education. She had no history of BCG vaccination. Full abdomen CT scan with contrast showed omental and peritoneal nodular thickening and multiple disseminated small-sized to enlarged lymph nodes in the pelvic, mesenteric, aortocaval, and paracaval regions. Findings extended to the pelvic region. Furthermore, the appendix is seen as fluid-filled and dilated, with adjacent minimal flat stranding densities and haziness. Irregular fluid collection with thick enhancing walls is also noted in the right pelvic region, suggestive of abscess formation. Further evaluation with transrectal ultrasound confirmed the presence of the abscess, showing fluid with heterogeneous echoes in the cul-de-sac. Chest X-ray was also done, which showed streaky and nodular opacities in the right upper lobe, and chest CT scan confirmed the findings with reticulonodular densities in the same lobe. Exploratory laparotomy, appendectomy, and biopsy of the mentum and peritoneum and peritoneal fluid cytology study were done. Histopathology revealed chronic granulomatous appendicitis with necrosis, necrotizing granulomatous inflammation in the omentum and peritoneum. Cytology revealed no malignant cells, and MTB PCR was positive for Mycobacterium tuberculosis. Final diagnosis is dry type tuberculous peritonitis with concomitant chronic tuberculous appendicitis. Patient was then started on oral TB medication. Co-occurrence of dry type tuberculous peritonitis and chronic appendicitis is a rare scenario. Findings raise several differential diagnoses, including infectious and malignant processes. TB peritonitis is classified into 3 types. The wet type is the most prevalent, seen in about 90% of cases, and characterized by abundant free-flowing or loculated ascites. In 60% of cases, the fibrotic type is observed, characterized by cake-like omental mass. The dry type is the least common type, observed in 10% of cases. It is identified by thickening of the peritoneum, omentum, and mesentery. Shows mesenteric lymphadenopathy and fibrous adhesions between bowel lobes, and was seen in our case. TB peritonitis is primarily due to hematogenous spread from a pulmonary source. It is treated with 6 months regimen of anti-TB drugs. Surgery is done for complications. TB appendicitis is rare. It may occur as a result of the appendix coming into direct contact, hematogenous spread, extension of ileocecal TB, retrograde lymphatic infection, or due to an inflammatory response. Chronic appendicitis is typically characterized by a milder but more persistent abdominal pain, with CT imaging revealing features similar to acute appendicitis. TB peritonitis and TB appendicitis may be accompanied with an abnormal chest imaging indicative of pulmonary TB. The patient's recent move to the Philippines, a tuberculosis endemic region, was a critical factor in the development of this unique pathology. Notably, as the patient was born and raised in the United States, she had not received the BCG vaccine, which likely contributed to her susceptibility to the infection. An understanding of radiologic findings can aid in diagnosis. For instance, omental and peritoneal nodular thickening, mesenteric lymphadenopathy, fibrous adhesions between bowel loops indicate dry-type tuberculous peritonitis. Although rare, dry-type TB peritonitis and or chronic TB appendicitis should be considered in patients presenting with nonspecific chronic abdominal pain, particularly in TB endemic regions. Early recognition and timely treatment of these conditions can prevent complications and significantly improve patient outcomes. Thank you so much for listening, and here are my references.
Thank you, Dr. Medina.
Good day.
An interesting case, and I see the level of support in the chat. Just a reminder again, this level of support should show by the end of the session during the poll when we list all the cases and ask you to vote for your favorite one. Okay, now moving to the 9th presentation from Vietnam, Dr. Gia Nguyen will be presenting about an emphysematous pyelonephritis on CT scan.
Dear committee, my name is Nguyễn Duy Nghĩa. I'm a PGI4 resident in internal medicine at the University in Hanoi, Vietnam, and I would like to present a case titled Emphysematous pyelonephritis on CT scan. My mentors are Dr. Opjun Chachu and Dr. Nguyễn Hà Ghi from Vinh University. So this is a 52-year-old female patient with history of bipolar disorder and hypertension. 2 weeks before this hospitalization, the patient was diagnosed with mild COVID-19 with managed symptoms at home. On the day of admissions, she has a fever of 38.5 degrees Celsius, accompanied by a progressive severe bilateral lower quadrant abdominal pain, which she described as a colicky characteristic, and watery diarrhea 5 times per day. Notably, the patient denies any symptoms of dysuria or changes in urine color. Physical examination was notable for the tenderness in the lower abdominal quadrants and positive left kidney allotment test. A lab test shows a highly elevated HbA1c count of 13.5% with a poorly glycemic control with a blood glucose level of 27 millimole per liters. She has an acute kidney injury with a creatinine level of 228 micromole per liters, and her inflammatory response was highly elevated with procalcitonin level of 140 nanograms per milliliters and a C-reactive protein level of 600. Her white cell count remains in the normal range of 7, but she does have a thrombocytopenia with platelets levels of 70. Notably, her urinalysis was negative for nitrates and shows only mildly elevated leukocyte count of 15 cells per microliters. Our patient presentations is not typical for a severe urinary tract infections, especially with the symptoms of acute progressive abdominal pain and diarrhea. Although she does have some left flank pain area. But her new diagnosed diabetes with poor glycemic controls and recent COVID-19 infections are risk factors for severe urinary tract infections. She was ordered imaging with abdominal X-ray, shows a bean-shaped gas distribution in the region of the left kidney, and her abdominal CT scan without contrast because of the acute kidney injury shows a destroyed left renal parenchyma with streaky and motor gas collection within that parenchyma, and with some crescent-shaped gas collections indicated by the blue arrows in the perinephric space. The frontal constructions of abdominal CT scan shows gas extending beyond the gyrus fascias to the left ureters and down to the pelvis, and this is consistent with Class 3B emphysematous pyelonephritis by Huang and Sangs. So she was diagnosed with emphysematous pyelonephritis with poorly controlled diabetes and COVID-19. She was admitted to the medical ICU and managed initially with fluid and meropenem and vancomycin infusions to provide coverage for the urinary tract. Blood cultures eventually shows growth of E. coli, which was susceptible to meropenem, and her condition gradually stabilized with medical management, and she received a left nephrectomy on July 30th with uncomplicated post-surgical period and she was successfully recovered and was discharged to home medication to manage her diabetes. So emphysematous pyelonephritis is a rare and life-threatening complications with severe gas-forming infections of the renal parenchyma and its surrounding areas. Diabetes is the most well-known risk factors for these severe conditions, with some suggestions of gas formations through the mixed acid fermentations of glucose by organisms such as E. coli or Klebsiella. And a case series in COVID-19 patients suggests that this COVID-19 could be a triggers for this emphysematous pyelonephritis in already at-risk patients. In our patients, the results of urinalysis is a misleading factors, and clinicians needs to be vigilant in interpreting the results and appropriately with the clinical pictures to improve the correct of the diagnosis. And our patient was managed with delayed surgical nephrectomy shows some approach could be successful in selected cases, even in patient with extensive emphysematous pyelonephritis. And this is my reference. And with that, I would like to end my presentation. I would like to thank the committee for your attentions. Thank you.
Thank you for this interesting case. And moving to the 10th presentation, a dual presentation actually from Dr. Yo-Yo Chu and Dr. Tang Vika from Hong Kong, who will be talking to us about a boy with progressive lower limb weakness.
Hello, everyone. We are radiologists from Hong Kong Children's Hospital. I'm Tang Vika. And I'm Dr. Yo-Yo Chu. And today we are here to present on a case of a boy with progressive lower limb weakness. So this is a 3-year-old boy with presented with refusal to walk and also progressive bilateral lower limb weakness. Initially, he could stand with support, but he later on was unable to bear weight or sit upright. He has a background history of global developmental delay as well as autism spectrum disorder. So extensive investigations was performed, including blood tests for autoimmune markers, for infections, as well as neuromuscular diseases. And all of those were unremarkable. And lumbar puncture, as well as MRI of the brain, whole spine, as well as both hips and thighs was performed, but none of them yielded results that could explain his symptoms. So later, the boy developed swelling in the right leg, and he came to us for ultrasound both knees to look for any effusion. We did not see any effusion, but we did find something else. So this is the ultrasound of the distal right tibia with the longitudinal and the transverse view. We could see that there is a heterogeneous hypoechoic rim overlying the bone cortex. And on the transverse view, it looks like a crescent-shaped hypoechoic layer. So findings are suggestive of the periosteal hematoma. So let's take a closer look at the metaphyseal region. We can see that there is a beaking or spur appearance at the metaphyseal region, and this is suggestive of a metaphyseal spur. So a diagnosis was later made with the blood test confirming hypophytaminosis C, which is also known as scurvy. And correlating clinical history revealed that the boy has been refusing main meals and only been eating biscuits since changing school half a year ago. So I'd like to talk more about the ultrasound features that we have illustrated just now. So the periosteum is more clearly visualized in children than adults on ultrasound. And normally it is seen as a thin hypoechoic band overlying the bone cortex. However, in the setting of scurvy, there is increased bleeding tendency. So it leads to elevation of the periosteum with thickening of the hypoechoic layer. However, it is important to note that this feature is non-specific, and it could also present in other conditions, such as subperiosteal abscess in osteomyelitis. So it is very important to consider the clinical context when interpreting the imaging findings. And the other feature we talked about is the metaphyseal spur. So in scurvy, osteoporosis is another major feature. Because of the weakened bone, there could be repeated microfractures at the metaphysis. So this leads to lateral growth of the metaphyseal calcification zone, resulting in this beak appearance. This is the radiograph frontal image of the distal right tibia taken at the time of the ultrasound. I'd like to bring to you the attention of another major feature that we could also see on the radiograph. So here we can see there's a loosened metaphyseal band at the Trommelfeld zone, which is just subjacent to the zone of calcification. There is also another point that I'd like to bring up in this radiograph. Literature has suggested that ultrasound may depict a periosteal reaction earlier than plain radiograph. So here we can see that the metaphyseal spurns of periosteal hematoma that were seen on previous ultrasound images are not as clearly delineated when compared with ultrasound. So I think our case have demonstrated this point for quite well. And this is the follow-up ultrasound of the right tibia. We could see that previous hypoechoic layer overlying the cortex has resolved. And this thin hypoechoic band is a normal-looking periosteum. So there's resolution of previous periosteal hematoma. So some take-home points for this short case is that, radiographic features of scurvy have been very well described, and there are also increasing reporting of MRI features of scurvy, but sonographic features are often overlooked and are seldom reported. Musculoskeletal involvement is the most common presentation of scurvy in children. And so ultrasound has added benefits of being radiation-free. It is also portable and time-efficient. So it could be a sensitive tool to evaluate features of scurvy and also for follow-up of treatment response in children. So thank you very much for your attention. Thank you.
It's an interesting case. Just want to thank everyone in the attendees for joining in, for tuning in and joining this session. There's around 170 participants taking a look at all the different presentations and posters. And moving to the 11th presentation, we are 3 away from having a 5-minute break. So we'll continue with Dr. Laura Agudelo from Colombia, presenting a case of an atypical presentation of extrapulmonary tuberculosis.
Good morning, everyone. My name is Laura. I am a second-year radiology resident at Universidad CES en Hospital Pablo Tobón Uribe in Medellín, Colombia. And today I bring you this atypical presentation of extrapulmonary tuberculosis. This is the case of a 15-year-old female patient born in Venezuela and currently living in Medellín with no history of immunodeficiency and was admitted to our hospital with 2 months of abdominal distension, intermittent fever, and weight loss with no relevant physical findings and initial laboratory tests which showed a slight elevation of the C-reactive protein with no other abnormal findings. A contrast-enhanced abdominal CT was performed, in which we see an alteration in the attenuation of the entire left hepatic lobe with a multiloculated hypodense lesion that showed slight enhancement of its walls and the septa within it. It measured approximately 10 by 7 centimeters and presented peripheral calcifications. Additionally, there was presence of adenopathies in the periportal space. These findings possibly related to a liver abscess, but this image was not completely characterizable in this imaging study. Therefore, an abdominal contrast-enhanced MRI was performed. In these images, we see hepatomegaly in the same lesion we were seeing in the CT scan, which behaves hypointense on both T1 and T2 weighted images. And this is important because the low signal intensity on both of these sequences revealed a necrotic component of the lesion, which made an abscess less probable and a malignant or granulomatous etiology more likely. The lesion had peripheral restricted diffusion. And in the contrast-enhanced sequences, it showed a progressive enhancement of its walls and the septa within it. There was also diffuse involvement of the spleen. And in this coronal view, we can see a compensatory hypertrophy of the right hepatic lobe with a left lobe atrophy and the mass occupying almost its entirety, which speaks to the chronicity of this lesion. Due to the fact that there were various possible diagnostic options, a biopsy of the liver lesion was performed. The pathology report showed extensive necrosis, making the definitive diagnosis impossible. The infectology department reevaluated the patient and ordered additional studies, which included a chest CT, in which we can see multiple mediastinal lymphadenopathies in the anterior, right paratracheal, and subcarinal spaces. The largest ones had peripheral calcifications and behaved similar to the hepatic lesion we saw in previous studies. These lesions were also biopsied, and a diagnosis of ganglionic tuberculosis was made. The case of the patient was then discussed by the infectology and surgery departments, and a decision to perform a left lobe hepatectomy was made due to the poor response to the anti-tuberculous treatment, the patient's deteriorating status, and the high probability of the lesion corresponding to hepatic tuberculosis. This is the surgical specimen that was obtained with a comparison to the MR image I showed you before, and the histology of the post-procedure biopsy, which was consistent with a giant hepatic tuberculoma. In regards to hepatic tuberculosis, it is 1% of patients with active TB. It presents between the ages of 11 and 50 years, and it is generally asymptomatic or with very nonspecific findings such as abdominal pain, hepatomegaly, and jaundice. There are 3 patterns of presentation. Micronodular, which is the most common form, is associated with disseminated disease and involvement of the lungs or spleen. The macronodular form, which is our patient's case, is very rare. It is an isolated disease, and it comes in the form of tuberculoma and tuberculous abscess. And the tuberculous cholangitis is the rarest form, and it's an involvement of the biliary tree. In the images of miliary hepatic tuberculosis, we see multiple hypodense lesions, less than 2 centimeters, with random distribution. In the macronodular form, we see a solitary or multiple masses with central necrosis and peripheral and septal enhancement. And tuberculous cholangitis shows ductal wall thickening and biliary tract dilation or stricture. The important points I want you to take home are that extrapulmonary tuberculosis should always be a differential diagnosis, especially in countries like Colombia, which is endemic, due to its high morbidity and mortality. The key imaging findings that should make you suspect this etiology are chronic changes of the liver with a poor enhancing calcified mass, similar findings in thoracic lymph nodes, and systemic involvement. Biopsy should always be performed to confirm the diagnosis, but it is important to rely on diagnostic imaging and multidisciplinary approach to determine diagnosis and guide treatment. And extrapulmonary tuberculosis, even with severe systemic involvement, is not unique to immunocompromised patients. Thank you to the special contributors, and thank you for listening to this presentation.
Another interesting case about TB from Colombia. Transitioning from South America to the Middle East, this next case is from Lebanon. Dr. Joris Allah will be presenting a case of imaging features of hepatic PCOMA.
Hello, everyone. I hope you're all doing well. Thank you for having me. My name is Joris Allah. I'm a first-year resident at the Department of Diagnostic Radiology at the American University of Beirut Medical Center, and today I'll be presenting a case titled Imaging Features of Hepatic PCOMA. So, 1 year ago, a previously healthy 13-year-old girl presented to our hospital with a 3-month history of the following symptoms: intermittent fevers reaching 38.5 degrees Celsius, generalized weakness, diffuse bony and abdominal pain, non-bloody, non-mucoid diarrhea, non-bloody, non-bilious vomiting, and significant unintentional weight loss. Lab tests were performed, and the results showed the following findings. The patient had significant anemia, mild leukocytosis, elevated lactate dehydrogenase, negative infectious workup, including viral tests, as well as testing for brucella and malaria, because the patient lived in an endemic area, negative anti-ENA screening, normal electrolytes and urinalysis, and normal liver function tests, renal function tests, and coagulation tests. The initial differential diagnosis included celiac disease and familial Mediterranean fever, as well as infectious conditions such as brucella and malaria, which were ruled out by our lab workup. The physical exam showed diffuse abdominal distension and tenderness with significant hepatomegaly, and family history was non-contributory. So based on the history, physical exam, and lab findings, the primary physician chose to order some imaging for the patient. She initially underwent MRI of the abdomen at our institution, and we can see here just a few examples of some images. So in figure A, we see a coronal fiesta sequence. Figures B and C show axial diffusion-weighted images, and figure D shows an axial lava flux sequence. Overall, the MRI showed multiple hepatic and colonic masses, particularly in the hepatic flexure of the colon, and these were characterized by hypo-intense signal on T1 weighted imaging, hyper-intense signal on T2 weighted imaging, diffusion restriction, and mild heterogeneous post-contrast enhancement in the arterial and portal venous phases. And as we can see here quite clearly, the largest mass occupied almost the entire right hepatic lobe, measuring 13.4 by 7.4 centimeters in size. The patient subsequently underwent PET-CT for further disease characterization. So we can see in Figure A the maximum intensity projection image, in Figure B a coronal fused image, and Figure C an axial fused image. And the PET-CT showed multiple lesions in the liver, hepatic flexure of the colon, and right lower quadrant lymph nodes that showed significant FDG uptake. So based on the imaging findings, the differential diagnosis shifted, and the primary suggested diagnoses were primary liver cancer, metastatic colon cancer, and lymphoma. We can also see here some CT images that the patient underwent showing an enlarged liver with large hypoattenuating heterogeneously enhancing lesions. A liver biopsy was then performed, and pathological analysis revealed the diagnosis of hepatic perivascular epithelioid cell tumor, also known as hepatic PCOMA. So PCOMA is a rare mesenchymal neoplasm that can affect various organs such as the liver, kidneys, and lungs, and it can be either benign or malignant. As the name perivascular implies, we can see a blood vessel in the middle of the image surrounded by neoplastic cells. I won't go into the details of the pathological analysis, but something to keep in mind is that PCOMA has a combined smooth muscle and mineralocytic differentiation. In the case of our patient, she had a rare mutation known as TFE3, and she was also PD-L1 positive, and unfortunately her disease was found to be malignant. So because the disease is quite rare and because there's no consensus regarding treatment and prognosis, extensive meetings were held to decide on the treatment approach, and this is what was eventually done. So she initially underwent right portal vein embolization to decrease the blood supply to the tumor and shrink it, followed by right hepatic lobectomy and right hemicolectomy with no complications. Subsequently, she was started on a triple regimen of treatment: sorafenib, a protein kinase inhibitor, sirolimus, an mTOR inhibitor, and to note that mTOR inhibitors have been shown to be effective in TFE3 positive cases, as in our patient, and cisplatin doxorubicin, of which she underwent 3 cycles before she was shifted to pembrolizumab, a PD-1 inhibitor, because the pathology showed that she was PD-L1 positive, and she's still maintained on all 3 of these treatments. So this is a PET-CT taken 1 year after treatment, showing no suspicious FDG activity, and the patient has been undergoing PET-CT images every 3 months with no recurrence or suspicious lesions. So overall, PCOMA is a rare mesenchymal neoplasm that can affect various organs and can be either benign or malignant. It has heterogeneous imaging manifestations, and the treatment is controversial and may include surgical resection, chemotherapy, radiation therapy, immunotherapy, and targeted therapy. These are my references, and thank you.
Interesting case, interesting
Hello, everyone.
Of pathology, radiology, and pharmacology as well. Moving to the last case presentation for this section. So after this case, we will have a brief intermission. Dr. Emmanuel Carlos Limos from the Philippines will be presenting a case of Berry syndrome.
Hello, everyone. I'm Emmanuel Carlos M. Limos, a resident from the Philippine Heart Center. I'll be presenting Not So Very Sweet, a rare case of Berry syndrome. So what are the radiological findings of Berry syndrome? Firstly, I'll be presenting a case of a 10-week-old male Filipino infant born term to a 32-year-old G6P6 mother via normal spontaneous vaginal delivery with good cry and activity and no cyanosis. With a chief complaint of tachypnea, patient's history started 2 weeks prior to admission with persistent cough and interrupted feeding, hence consult. A 2D echocardiogram was done and showed abnormal cardiac anatomy and was then referred to our institution for cardiac CT angiogram and surgical management. Patient was then presented to the ER with the following vital signs: pulmonary physical exam findings, and cardiovascular physical exam findings. Patient was then admitted as congenital heart disease, a cyanotic type. For the initial imaging, the 2D echocardiogram in this parasternal long axis view showed an interrupted aortic arch. So the aorta is interrupted after the level of the left subclavian artery, as seen in this image pointed out by the yellow arrow. It is also confirmed in this sagittal oblique view in the cardiac CT angiogram done in our institution. We see a left-sided aortic arch, and the aorta is interrupted after the level of the left subclavian artery. Another feature of Berry syndrome, seen in this axial oblique maximum intensity projection, is that the descending aorta is opacified by a patent ductus arteriosus-like structure arising from the pulmonary trunk. Another feature of Berry syndrome, seen here in this 2D echocardiogram subcostal view, that the anomalous right pulmonary artery arises from the ascending aorta through the aortopulmonary window, as pointed out by this yellow arrow. In this axial oblique maximum intensity projection view, we see that there's abnormal communication between the proximal ascending aorta and right ventricular outflow tract, representing the aortopulmonary window. The right pulmonary artery arises from the ascending aorta, and the left pulmonary artery arises from the main pulmonary artery. Moving on to the discussion of Berry syndrome. So it is first reported by Teresa Berry in 1982, and it is extremely rare. Only 0.046% of all reported cases of congenital heart anomalies are of Berry syndrome. For its embryological etiology, so we see the possible embryogenesis described by Berry shows that when the aortopulmonary septum fails to form, a large aortopulmonary window is then presented. It represents a partial persistence of the common arterial trunk. Affected by this, the 6 pharyngeal arches may fail to form a bifurcation and may attach improperly to the undivided truncal segment. This results in the wide separation between the right and left pulmonary arteries, and in turn, an abnormal origin of the right pulmonary artery is formed. During fetal development, the aortopulmonary window and abnormal origin of the pulmonary artery could reduce blood flow in the aortic arch, leading to an interrupted aortic arch. In conclusion, for our patient was successfully operated on with repair of the aortopulmonary window and interrupted aortic arch. We see here in this axial maximum intensity projection image that the aortopulmonary window is repaired and the main pulmonary arteries are confluent. For the key points, we see that CTA findings of Berry syndrome are type 2 aortopulmonary window, type A interrupted aortic arch, patent ductus arteriosus, and the right pulmonary artery arising from the aorta. Transthoracic echocardiography is the initial diagnostic tool in the evaluation of Berry syndrome. Computerized tomogram angiography and 3-dimensional reconstruction are used to ascertain the anatomy in patients with Berry syndrome. Proper understanding and anatomical identification through these modalities is used to determine the best surgical outcome for patients with Berry syndrome. These are my references. Thank you for listening.
Awesome case. As we said, now is the time for the intermission. This is the QR code to view the posters. Please give them a look, take a look at them. Very interesting cases. I will leave you for around 5 minutes to with some music, and we'll be back. Thank you for joining. Okay, welcome back, everyone. We will resume the oral presentations. We have 12 more presentations to go through, and I hope you enjoy. Let's move on to Dr. Muhammad Zalouk from Egypt. He will be presenting a case of caposiform hemangioendothelioma, a treatable cause of limb overgrowth.
Hello and welcome. I'm Mohammed Adel Zalouk. I am a second-year resident at the Diagnostic and Interventional Radiology and Molecular Imaging Department at Ain Shams University, Cairo, Egypt. And I will be presenting today a case of capuciform hemangioendothelioma, a treatable cause of limb overgrowth, under the supervision of Professor Dr. Shayma Abdel Sattar Mohammed of the Diagnostic and Interventional Radiology and Molecular Imaging, and Professor Dr. Amr Abdel Hamid Abu Zaid, Department of Pediatric Surgery. Our case here is a 3-day-old boy complaining of overgrowth of his right lower limb. As you can see, it's enlarged and it has a dusky red color, which is very suspicious for vascular lesions. And as we did the CBC, it shows decreased platelet count. Well, the diagnosis was not yet reached. The history is inconclusive, so we have requested that MRI imaging. Multiple conventional and dynamic post-contrast MRI angiographies were required and were requested and acquired. It showed extensive overgrowth of the right lower limb involving thigh, leg, and foot. It showed ill-defined soft tissue thickening involved in the skin, subcutaneous tissue, muscles, and intermuscular fat planes, all exhibiting hyper-intense signal on T2 weighted images with early soft tissue enhancement. MRI findings also showed that the vessel supplying the right lower limb is dilated with multiple small branches, yet no arteriovenous shunting detected. Here we can see the dilated vessels. As the patient received steroids and vincristine for 6 weeks, we found remarkable improvement in the platelet count and the lower limb swelling. This made us reach the conclusion that this was a case of capuciform hemangioendothelioma, which is a benign yet aggressive vascular tumor occurring mainly in infants. It can present with highly variable clinical picture according to site and size of the lesion. It is associated with Kasabach-Merritt syndrome, in which there is platelet consumption leading to petechiae. Also, there is distended abdomen, tender lesions, and giant hemangiomas found in the same patient. A vital point to consider here is that the disease is relatively rare and unknown to physicians, leading to a higher possibility of missing the diagnosis and suboptimal management till confirmation of the lesion nature by biopsy. The best imaging modality used in the diagnosis of these cases is the ultrasound, but for small and superficial lesions, while contrast-enhanced MRI and MRI angiographies are best for more complex lesions, as our patient here. The findings include transfacial lesions crossing more than just a layer of tissue, high signal intensity in T2 and stir enhancement in the subcutaneous tissue in the form of striations. While the differential diagnosis here includes congenital hemangioma, congenital fibrosarcoma. The congenital hemangioma here can show in the MRI hyperintense signal on T2 weighted images, while hypointense on T2 and T1 with multiple signal voids and post-contrast enhancement. It is clinically diagnosed, but when in doubt, we might need biopsy as well. While fibrosarcoma will show intralesional hemorrhage with evidence of bone and muscle infiltration. Our take-home messages here is that the clinical picture of the capuciform hemangioendothelioma is tricky and variable. We will consider it in patients with limb overgrowth. Best imaging modality, as we have said, is contrast-enhanced MRI studies. The disease is associated with low platelet count, and we will consider it in infants unresponsive to the treatment to elevate the count of the platelets, and multidisciplinary teams as a concept is of great importance. These are the references, and thank you very much.
Thank you to Dr. Muhammad. Moving to the second case, it's Dr. Yuri Shendelacerda from Brazil, who will be talking to us about Katayama fever in a 24-year-old traveler. 25, sorry.
Hello everyone, my name is Yuri Shin. I'm presenting a case of Katayama fever in a 25-year-old traveler from Instituto de Radiologia do HCFM USP, Brazil. I'd like to thank my team member Israel and my mentor Eduardo Kaiser. There are no conflicts of interests. APB is a 25-year-old female who presented at our emergency department with fever, severe occipital headache, dizziness, right-sided paresthesia, and hemiparesis, and oscillopsia, which is a constant visual sensation that the environment is moving, during 1 week. Her past medical history was unremarkable, except for a recent trip to her hometown 2 months before. There she swam in a river and developed pruritic erythematous lesions on her thighs, which cleared shortly before the commencement of her neurological symptoms. Her laboratory results showed only significant eosinophilia. A head and neck CTA was requested to investigate her symptoms. As we can see, there is a volumetric enlargement and hypoattenuation of the pons with reduced amplitude of adjacent cerebrospinal fluid spaces. As additional findings, there were pulmonary nodules with ground glass halos, configuring the halo sign in the cervical-thoracic transition. Some differential diagnoses were considered, such as Churg-Strauss hypereosinophilic syndrome and a disseminated parasitic infection. For further investigation, CT and MRI scans and a lumbar puncture were requested. Her chest CT confirmed the presence of numerous peribronchovascular nodules with ground glass halos scattered throughout both lungs. There were no significant findings on the MRI of the orbits and spine or on the abdominal CT. The analysis of her CSF confirmed hypercellularity with 26% eosinophils. These findings raised concern for a widespread parasitic infection. This was her brain MRI, the T2-weighted image, and these are the flare sequences. It was much easier than in the CT images to characterize this heterogeneous lesion with a tumefactive appearance in the pons, cerebellum, and midbrain, more pronounced on the left side. The post-contrast images show the perivascular enhancement, sometimes with a discrete nodular and linear pattern. The diffusion-weighted images and ADC map showed no diffusion restriction, indicating that it was not an abscess or a hypercellular lesion. The colored RCBV map showed no hyperperfusion on the DSC sequence, meaning it was a cold lesion. The diagnosis of acute neuroschistosomiasis was confirmed by a positive IgM for schistosoma in the CSF. Unfortunately, despite adequate diagnosis and commencement of treatment, her condition deteriorated quickly and she passed away. Schistosomiasis is a neglected tropical parasitic disease caused by traumatose in the genus Schistosoma. In South America, we have the Schistosoma mansoni. The other two main species that affect humans are Hematobium in Africa and Japonica in China and Southeast Asia. It affects over 250 million people worldwide, mostly poor and rural communities, particularly agricultural and fishing populations due to exposure to contaminated water. Human infections acquired through direct contact with water. Fresh water containing the cercaria, which is the larval infective form of the parasite, which penetrate the skin, migrate via venous circulation to the lungs and into the liver, and mature in adult worms within weeks. The female worms produce eggs that travel to the bladder for the S. hematobium or intestines for the other two species. The eggs are eliminated with urine or feces, hatch, and release miracidia, which swim and penetrate the intermediate hosts, which are specific freshwater snails. In the human host, some eggs may be trapped in body tissues, and the symptoms are caused by immune reactions due to their presence. The three main forms of the disease are the allergic dermatitis or swimmer's itch, which is a self-limited hypersensitive and pruriginous reaction due to the penetration of cercaria, the Katayama fever, which happens 3 to 8 weeks after primary exposure. This period marks the schistosomes' first egg production in the human host, which are highly immunogenic. There is marked peripheral eosinophilia, and the disease is usually self-limited but can result in death in severe cases. It is commonly seen in travelers through endemic regions. And the chronic schistosomiasis, which is an immune-mediated granulomatous response to the eggs. It can cause hepatic fibrosis, pulmonary hypertension, increased risk of bladder cancer, and fibrosis. Lesions in the CNS are rare and result from the ectopic deposition of eggs in the spinal cord and brain. The CT typically reveals abnormalities in the lungs, even in the absence of symptoms, which are usually small scattered nodules, sometimes in the halo sign. For the CNS, a characteristic pattern of clustered nodular enhancement at the MRI may be useful for the diagnosis, which is confirmed with the identification of eggs in stool or urine or antibody detection. The main drug for treatment is praziquantel, which is effective against all schistosoma species. The key to the diagnosis is to consider the possibility in the first place, so we must know the disease and think about it, mainly for travelers and residents in endemic areas. The three main forms of the disease are the allergic dermatitis, the Katayama fever, and chronic schistosomiasis. For the CNS, a MRI pattern of clustered nodular and linear enhancement may be useful. For the lungs, the main findings are small scattered nodules, sometimes with the halo sign, and the disease can be controlled with adequate treatment, sanitation, access to potable water, and control of the snail population. These were my references. Thank you very much for your attention.
Awesome case.
Hello, everyone.
Brazil. Moving to Asia, to Vietnam, Dr. Phong Nguyen will be presenting a case about bone invading the brain from Vinh University.
Hello everyone, my name is Dr. Phương Nguyễn Thị Hoài, a PGY4 pediatric resident at Vinh University, Hà Nội, Việt Nam. Today I will presenting a case titled Bone Invading the Brain with no disclosure to report. This case was supervised by my mentor, Dr. Ngọc Nguyễn Văn, an attending physician at the Department of Neurosurgery, Vietnam National Children's Hospital. A patient is a 9-year-old girl with a 2.5-year history of subdural hygroma. She initially presented with left focal epilepsy, macrocephaly, and mild developmental delay in February 2022. In July 2024, she returned to the hospital with acute severe headache and recurrent vomiting, which indicate a rise in intracranial pressure. A brain CT scan from the February 2022 showed a 39 millimeter thick subdural hygroma on the right side, as you can see in the red circle, and the left ventricular dilation. At this time, the baby have no indication for surgery. She just received the anesthesia medication and outpatient follow-up. By July 2023, the patient's symptom has worsened with increased intracranial pressure size and left hand tremor. A new brain CT revealed an enlarged subdural hygroma, meningeal calcification, and a midline shift. This necessitates a subdural peritoneal drainage surgery. Despite initial improvement, the patient was readmitted with a suspected SMART. A new CT scan showed an enlarged hygroma, a skull destruction due to an underlying tumor. During surgery, the surgeon also discovered the tissue deposit within the chamber of the subdural peritoneal shunt and the right frontal lesion. Destroyed the bone marrow of the skull, invading the fascia and muscle tissue. Further investigation revealed a mass in the right ovary discovered via abdominal CT scan. Lab pressure, including the beta-HCG and AFP level, was normal. Tumor biopsy and tumor immunohistochemistry have to go to the final diagnosis on differentiated pleomorphic sarcoma with no evidence of angiosarcoma. The patient underwent the external subdural drainage and later received a subdural peritoneal shunt. Post-surgery there were no seizures aside increased the intracranial pressure. Further management will involve the pediatric oncologist with discussion potential chemotherapy and additional surgery for this patient. To conclude, undifferentiated pleomorphic sarcoma is extremely rare in children, especially when involving the bone, as in this case where the tumor invading the skull. Early diagnosis through imaging, histopathological confirmation, aggressive surgery management are key to improving the patient outcomes. Chemotherapy and radiation may be necessary in case with the high risk of recurrent metastasis. Here are the references used to support this case and its discussion. Thank you for listening.
Thank you for this awesome case. Coming up is a case from Pakistan, Aga Khan University. Dr. Fatima Bojani will be discussing ALERD, or acute encephalopathy through restricted diffusion.
Good morning, everyone. My name is Dr. Fatima Bojani. I'm the FO resident radiology in Radiology Department of Aga Khan University Hospital. The topic of my today's case presentation is acute leukoencephalopathy with restricted diffusion, shedding light on a lesser known cause of encephalopathy in intensive care children. My mentor for today's presentation is Dr. Kiran Hilal and Dr. Kamal Khanwala, and my team member is Dr. Abdur Rahman, who's an Air 2 resident in Radiology Department. Now, starting with brief history of our case is about a 1-year-old boy who came to Aga Khan University Hospital Emergency Department with complaints of fever, vomiting, and loose stool for 3 days. He also had an episode of seizure. On examination, he was dull, lethargic, had altered GCS with increased tone in both upper and lower limbs, with tachycardia and low blood pressure. His initial lab workup was positive for metabolic acidosis. His blood culture came out to be negative, and his CT head was unremarkable. In ER, he was managed on the lines of septic shock, given anti-epileptics due to posturing, and was eventually intubated and shifted to intensive care unit. In ICU, he further underwent investigations, which included CSFDR and CS and biofire film array. His CSFDR showed raised leukocyte count, mildly raised leukocyte count. Therefore, he was started on antibiotics in meningitic doses. However, his CSF, CS, and biofire film array came out to be negative. He was additionally tested for dengue infection, which came out to be positive. He underwent MRI brain examination. These are the key images from MRI examination. On the left side of the screen, we can see T2 weighted sequence, and on the right side, we can see T1 post-contrast sequence. On T2 weighted sequence, we can see subtle hyperintense signals in the gyri of both cerebral hemisphere and bilateral basal ganglia, suggesting mild edema. On T1 post-contrast sequence, we do not see any abnormal enhancement of the brain parenchyma. Its DWI sequence showed bright signals in the subcortical and deep white matter, diffusely involving both cerebral hemispheres, and these signals appeared as low signals on ADC sequence. So these showed restricted diffusion in the subcortical and deep white matter in a typical bright tree pattern. Based on these findings, a radiological diagnosis of ALERD was made. The child, despite management, did not neurologically improve, and his family was counseled regarding his prognosis. His court status was changed to do not resuscitate. After hemodynamic stabilization, he was stepped down to ward, however, did not improve neurologically and was discharged with neurologic impairment. Now, discussion about ALERD. ALERD is most commonly triggered by infections. It has typical appearance of restricted diffusion in the subcortical and deep white matter, giving typical bright tree appearance, mostly seen in Asian population, and can rarely be due to non-infectious causes. MRI is the diagnostic investigation choice for ALERD. These are companion cases from our department. This is a case of a 9-year-old boy who came with sore throat and fever. He had an episode of seizure during his hospital stay, because of which MRI brain was done. As you can see on the MRI brain, there is restricted diffusion in the subcortical white matter in both cerebral hemisphere and was radiologically diagnosed as ALERD. His blood workup was positive for diphtheria, so this was a case of infectious ALERD. Another case of ALERD in which the child presented with high-grade fever and generalized seizures. We can see that on DWI and ADC sequences, bright tree appearance of diffusion restriction in both cerebral hemisphere. The child blood culture came out to be positive for budding yeast, so this was also a case of infection ALERD. Now, The take-home message from our presentation is that MRI, particularly DWI, plays an important role in the workup of children with acute leukoencephalopathy, as it helps in making the correct diagnosis, institution of appropriate treatment, and prognosis. Another takeaway point is that in alert, sometimes initially the MRI may be completely normal. So if you're suspecting alert in a patient, you should repeat an MRI after 3-4 days. Now, these are my reference articles for today's presentation, and this brings our presentation to an end. Thank you, everyone.
Another case just showing the importance of radiology and the management of different pathologies. I would like to thank everyone who is joining this session. We're up to almost 200 participants. Thank you for always tuning in. Don't forget to check the posters and also enjoy the presentations. Coming up is a case from Ethiopia. Dr. Henok Ayene will be presenting a case of very rare case of Rachipagus para a very rare case of Rachipagus parasitic twin limb with meningomyelocele, scoliosis, and diidal futurus of autozoid twin.
Hello everyone, I'm glad to be here. I will be presenting a very rare case of Rachipagus parasitic limb with multiple anomalies. My name is Dr. Henok Ayene. I'm a severe radiology resident in the Department of Radiology and Radiology in St. Paul Hospital in Ethiopia. These are my team members, and I want to thank you to my mentor, Dr. Mohammed Bali, for his guidance. So this is a 24 days old female unit present with notable swelling in the lower back, accompanied by an extra limb protruded from the dorsal region. It was a home delivery from a paratomother, and there was no MC follow-up. And on physical examination, there was a skin-covered extra limb attached to the back, having a muscle, and there was rudimentary digits. Above it, there was also midline mass measuring 6x5 with overlying skin defect, but there was no discharge. And the left findings are within the normal limbs. As you can see, this is a clinical photograph showing the extra limb attached to the back, and this is the hypoplastic rudimentary digits and soft tissue mass above this limb area. So with this, the clinical diagnosis of extra limb considered, and MRI was ordered. So this is sagittal and RDL T2 MR image showing a large vertebral posterior ligament defect with this cystic area having a communication with the sacral canal, and you can see the neural plaque herniating into this cystic collection, and you can also see this herniation of the CSF and the vertebral posterior ligament defect, and the conus is found to be low-lying, suggesting T-Z cord syndrome. So these are the consecutive T1 coronal MR image showing the hemivertebra of L3 and resulting in levoscoliosis. And this is an extra limb containing the femur hemipelvis articulating the lumbosacral region and hypoplastic femur in the fibula and also the digits. And that's also axial T1 and T2 image showing two separate endometrial canals. They fused at the lower uterine segment, suggesting diidal uterus. So with this, the diagnosis of Rachipagus parasitic limb with meningomyelocele, hemivertebra, T-Z cord, scoliosis, and diidal uterus of the autocyte twin was diagnosed, and patient went to OR. Surgery was performed when the baby was 1 month old, and there was an electrical incision based was excised the parasitic limb, and there was a bone communication with the lumbosacral area, and a bone component was appreciated. MMC is the meningomyelocele is also repaired, and the tissue was sent for pathology. So this is the annexed dose specimen showing the skin-covered limb and hypoplastic limbs, and also a partial encapsulated cystic structure are also appreciated. And in the following week, the histopathology is confirming the presence of an ectopic mucosa and a parasite limb, and the patient was the post-op recovery was smooth. There was no neurological deficit. The wounds were clean, and the patients were discharged after 1 week. You can see it's on this picture. So come to the discussion, conjoint wound. It results from two complex pathologies, the usually unite in one of the 8 anatomy sites. So the classification of conjoint wound comes from the area of where the communication is seen. So parasite wound is it is a subtype of conjoint wound when one of the fetus is detected, so that majority of the organs will be resorbed and there will be externally attached to the outer side wound. So Rashipagus parasite wound is an extremely rare congenital anomaly characterized by attachment of the parasite to the vertebral column of the host wing. They tend to have variable morphology, but commonly they will have supernumerary limbs, and they can also be associated with the CNS and vertebral column malformation of the outside wing because of they do have the dorsal communication with the outside wing. So mitochondrial is MRI is key for diagnosing the Rashipagus parasite twin, looking for multiple associations of the outside twin, and working in a team is always good. So it's a multidisciplinary team is very important for effective management and surgical planning, especially in our case, like involving complex anomalies. So these are my reference. Thank you.
Well, that's a case you don't see every day with rather impressive images. Thank you to Dr. Ayene from Ethiopia. I just want to point out that the call to vote for your favorite oral presentation will be up after all of the presentations are done. We are almost there. We have 7 more presentations to display from different countries, so please stay tuned and enjoy the educational presentations. Coming up is another case from Vietnam. Dr. Le Van Can will be presenting a case of fasciola masquerading as biliary tumor.
Hello everyone, my name is Van Khanh and I am from Vinh University, Vietnam. Today I'd like to present the case of fasciola masquerading as biliary tumor on PET-CT and MRI imaging. Before I start, I'd like to take time to thank the medical faculty at Vinh University and the radiology team at VinMec, especially my mentor, who bring me this amazing opportunity. So our case today is of a female, 44 years old Vietnamese who been well before presenting with GI pain, reflux, and bloating for a month. The pain is sharp and is not resolved or made better by PPI. There is no fever, no jaundice, no bowel movement change, no significant medical history, family history, or traveling history reported by the patient. She simply go to the clinic to check up on a pain that had been happening for 1 month. The physical examination of the patient is significant for tenderness in the epigastric region of the abdomen, and there's no fever, no distension. The lab is normal, including CBC with differential and metabolic panel. Further testing of liver function is also normal. So now, of all the imaging that we've done for this patient, I'm going to present some of the key imaging. So the first thing that you see on T2 weighted MRI right here is the biliary tract dilation shown in blue arrow. So after that, we've done a variety of sequences of phases, and we found abnormal thickening with gadolinium contrast uptake on T2 weighted sequence, on diffusion sequence, on phases like delayed or arterial phases. So with that in mind, we are currently thinking of a tumor at the location with the yellow arrow, right? So we move on to other imaging modality to either confirm or deny it. And we chose the PET-CT. So on the PET-CT, we found a thickened border and variable contrast uptake at the same location. And on the PET, the significant FDG uptake prompts us to think that this is either an ongoing inflammation or a tumor. However, if it's an ongoing inflammation, there should be either hemodynamic change or there should be physical presentation like fever or recent fever, which all of that our patient doesn't have. So we lean more toward a tumor. And at this point in time, due to the location making it impossible for sampling for biopsy, we just depend on the location mostly and the imaging characteristic to give the diagnosis of Klatskin tumor of the biliary tract. And because of the high risk of carcinoma, we sent the patient right for hepatectomy and a bypass. And then after the surgery, the sample will be sent to pathology, and turns out the patient is not having carcinoma. It is fasciola. It is a fluke in the biliary tract. So our patient here obviously have the second stage of fasciola, the biliary stage, where it happened after 2 or 3 months of the hepatic invasion of fasciola. So the time that it takes for the fasciola to reach the biliary tract, it's explainable for the normal lab test that we saw earlier of the patient, right? And also, this is an atypical case because in Vietnam, cases are reported, and also globally, cases are reported of fasciola is of a cluster of lesions forming circular or oval nodules with liver parenchyma damage, which in this case is absent, is a kind of nodule that we see with various contrast uptake, and combined with the lab result is less suggestive of a fluke. And with that, you might think that that's the end of our case, but no. 1 year and 5 months later, the patient complained of a GI pain that did not respond well to treatment, and imaging at this time showed biliary stone. And the patient then have to go through another procedure to help remove the stone. And not to mention that earlier they also have the leakage of the surgical sign 10 days post-op. So the takeaway point from this is that if you or your patient is in a tropical location, please put in the back of your mind that the thing that you see might be an atypical presentation of a tropical disease, like in this case is a fasciola. That can help preventing unnecessaries for the patient and for you, and also lessen all the burden that the healthcare tech have on the patient and the healthcare facility itself. So that's all for today. Thank you very much.
Yes. Another interesting case with regional significance.
Hello, everyone.
So just a reminder for you to check all the posters. The link is posted in the chat box. Regarding voting for the posters, it will take place after the session through a red cap link that we will circulate among you, and it will stay open till mid next week. I will follow up via email with all the attendees and share the link with you again. Yeah, so that's it. Now moving to India, Dr. Lakshmi Malia will be presenting a case of scrub typhus epidemic at its worst, a pediatric imaging case report.
Good morning, everyone. I'm Dr. Lakshmi Malia from Department of Radiodiagnosis, SMS Medical College, Jaipur, Rajasthan, India. My presentation is on scrub typhus epidemic at its worst, a pediatric imaging case report. I do not have any disclosures to make. Patient profile: a 13-year-old male child came with complaints of fever and altered sensorium. There was no significant congenital and past medical history. The mother is a homemaker and father is a farmer by profession and belongs to low socioeconomic background. On clinical examination, there was tachypnea, altered sensorium with GC score of 8. There was no focal neurological deficits. There was hepatosplenomegaly with blood pressure and saturation within normal limits. There was no evidence of any skin lesions. Lab investigation showed raised WBC counts with neutropenia and lymphocytosis. There was anemia, thrombocytopenia. Rapid diagnostic tests showed positivity for both dengue and scrub typhus, which was simultaneously declared an epidemic in the region. Eventually, IgM ELISA test came out to be positive for scrub typhus, which is more specific. Bedside ultrasound detected extensive peri-GB edema. 2D echo ultrasound revealed loculated pericardial effusion. CCT chest images detected ground glass opacities and interlobular septal thickening in bilateral lung fields, predominantly in the lower lobes. Mediastinal window showed mediastinal lymphadenopathy with bilateral pleural effusion. There was constrictive pericarditis changes with thickened pericardium and pericardial effusion, with upper sections of the abdomen showing congestive liver changes and dilated hepatic vein suggestive of congestive liver due to congestive cardiac failure. The patient's altered sensorium did not improve, for which he further underwent MRI study, which showed that there are intralobar hemorrhages of varying stage. There is diffuse cerebral edema with midline shift towards right side. Overall features of acute hemorrhagic encephalitis was detected. So the overall diagnosis is scrub typhus with interstitial pneumonitis, mediastinal lymphadenopathy, constrictive pericarditis, and acute hemorrhagic encephalitis. The child was initially managed as dengue-like illness, which is a very close differential of scrub typhus. Dengue was declared as an epidemic, simultaneously making it very difficult to make a clear distinction between the two clinically. Scrub typhus was confirmed with IgM ELISA test, and the patient was given a course of IV doxycycline for 7 days, followed by which the patient's GCS improved to 13. IV doxycycline is a preferred choice for children above 7 to 8 years of age. If the child would have been less than 7 years of age, then azithromycin would have been a choice. The patient drastically improved, and on the day 14, the patient left against medical advice due to personal reasons. Scrub typhus is a zoonotic disease which is caused by Ornithia susugamushi, an obligate intracellular parasite transmitted by the vector trombiculid mite. Humans are accidental hosts. The favorable environment for these organisms is humidity and rainy season. It is prevalent in equatorial rainforest and semi-desert region. A geographical area of importance is the Susugamushi Triangle, which consists of Japan, Taiwan, and China in the north, Australia and Indonesia in the south, India and Nepal on the west. Now, Rajasthan, an arid and semi-arid state of India, which observes hot climate in summer and rainfall less than 20 mm, which is the normal scenario. But in 2024, many villages and major cities of Rajasthan experienced very heavy rainfalls and floods, which was recorded to be 994 mm, which is 102% times more compared to last year. And this justifies the alarming rise of outbreaks that we are observing this year with simultaneous outbreaks of dengue. Take-home points. Scrub typhus is a re-emerging acute febrile illness and has a high mortality up to 70% if untreated. As scars seen at the site of bite is not commonly seen in Asian population. Currently, many parts of Rajasthan in India is battling simultaneous outbreaks of dengue and scrub typhus. Hence, a multidisciplinary approach is the key in significant reduction of patient mortality.
Well, thank you to everyone from the Asia's, East Asia, South Asia for tuning in. I know it's getting late in that part. We have 5 more presentations to go through. I would just like to clarify that after the 5 presentations are done, we will have a poll for the attendees to vote for their favorite oral presentation. However, the posters will be voted in a separate link, a red cap link, where you would provide feedback and vote for the favorite posters. And the winners will be announced later on during the following week. Whereas the oral presentations, People's Choice Award, and the winners, the first 3 places, will be announced today. And moving forward to Dr. Muhammad Rafai from Pakistan, who will be presenting a case of rabies encephalitis, a tragic outcome despite timely prophylaxis.
Hi everyone, my name is Dr. Mohammad Rafe and I am from Department of Radiology at Aga Khan University Hospital, Pakistan. Today I am presenting a case of rabies encephalitis focusing on its imaging finding and important diagnostic consideration. So I have an 8-year-old boy who was admitted with complaint of fever, drowsiness, and decreased consciousness. He had no significant prior medical history and had been treated locally for meningoencephalitis for 1 day. 20 days before admission, the patient was bitten by a dog of unknown rabies status. He had undergone post-exposure prophylaxis, which include rabies immunoglobulin and 3 doses of rabies vaccine. On arrival, the patient was lethargic and the vital was like he has tachycardia and tachypnea. CNS examination was done and patient shows lethargic with GCS of 10 and brisk and reflexes with mute plantar response. Initially, the laboratory investigation was done and it shows unremarkable. So neurology team was on board and they advised enhanced CT brain. So enhanced CT brain was performed. There is a picture of CT axial section of CT scan and coronal section, which shows subtle loss of normal gray white matter differentiation in the bilateral basal ganglia with surrounding hypodensity, more pronounced on the right side. This finding raised a suspicion of rabies encephalitis. So the ID team was consulted and they advised intravenous antibiotic and antivirals. So the child was deteriorating and he had low GCS. So he was shifted to PICU and he will get intubated. Neurology team advised MRI brain, which shows there's a picture of T2 weighted image of MRI axial view, which shows hyperintense signals in the basal ganglia, thalamus, and pons. There's a flare image, coronal flare image showing hyperintense signal in basal ganglia. There was no diffusion restriction on these images in the involved area, and there was no diffusion restriction at the level of mid-brain. And on T1 weighted image and T1 post contrast, there was no post contrast enhancement, and there was no signal dropout on SWI. So rabies is one of the most fulminant neurotrophic disease in our South Asian region. And initially, the typical presentation does not lead to the radiological imaging study. So the radiological imaging study is rarely performed in this scenario. So the radiological imaging like MRI can reveal specific changes in the brain associated with rabies encephalitis. Few cases has been reported which shows a diffusion restriction, but in our scenario there was diffusion restriction. So the key radiological feature, the takeaway of this presentation is the symmetrical T2 flare hyperintensities in basal ganglia and thalami and dorsal brainstem. Which can show in rabies encephalitis. This has to exclude like ischemic encephalitis, like we can see this dropout signals diffusion weighted restrictions in ischemic encephalitis, and there was a second takeaway of this presentation is a public health implication because importance of public health measure including vaccination, education about rabies prevention to reduce the incidence of this fatal disease. So thank you so much to all of you. This is Dr. Mohammed Rafi. Thank you.
Thank you, Dr. Rafi, for this interesting case. Moving to Lebanon, Dr. Emmanuel will be presenting a case of multifocal paraganglioma in a 28-year-old male. Let's see what we have from Lebanon.
Hello, everyone. My name is Emmanuel Amanoui. I'm a PGY5 radiology resident at the Lebanese American University in Beirut, Lebanon. And for the global case competition, I'm going to be presenting a case of multifocal paraganglioma in a 28-year-old male under the supervision of Dr. Julie Fersley. I would like to thank all our team members, Dr. Nabil Mkerzel, Dr. George Ghanem, and Dr. Varun Karam for contributing to the case. We have no conflict of interest to declare. So it's a case of a previously healthy 28-year-old male patient who presented to the cardiology clinic with nonspecific angina-like chest pain and palpitations. The patient had no smoking history. He reported no alcohol abuse or use of illicit drugs. He had no past medical or surgical history. His physical exam was unremarkable and all his labs were negative. The transthoracic cardiac ultrasound was performed and showed the presence of a well-defined retrocardiac mass for which a cardiac CT was obtained. And it showed a 4 centimeter hypervascular mass at the left atrioventricular groove that was seen encasing the left circumflex coronary artery, as depicted here by the image, and was likely responsible for the patient's presentation. A cardiac MRI was also obtained and showed a well-defined mass at the left atrioventricular groove, showing preserved fat planes with the adjacent structures, mainly the cardiac wall, and it showed no malignant features or invasion of the surrounding organs, and it exhibited high to intermediate cyclic intensity on T2 flare sequences. The diagnosis of cardiac paraganglioma was suggested, and PET dotatate was recommended for further investigation. And indeed, it showed increased uptake at the level of the retrocardiac mass as depicted on the image on the left. And on the right, we noted multiple foci of increased uptake at the level of the neck, mainly at the parapharyngeal and laryngeal regions, for which a contrast-enhanced neck CT was obtained and showed a 7 mm hypervascular nodule at the right area epiglottic fold and hypervascular nodules at the carotid bodies, measuring 12 millimeters on the right and 7 millimeters on the left. So the diagnosis of a multifocal neuroendocrine disease was suggested. The plasma and urine metanephrine and catecholamine levels were elevated, so the diagnosis of a multifocal functional paraganglioma was established. Genetic testing, as recommended, showed no pathogenic gene alterations in relation to the patient's phenotype. The patient is under close clinical monitoring with a multidisciplinary team discussing potential surgical interventions given the complexity of the case due to the cardiac involvement and multifocal nature of the disease. Multifocal paragangliomas, including the cervical sympathetic chain origin, are exceedingly uncommon. 20% of cases are in the pediatric population, with 10% of cases being multifocal. Mutations in the SDHB and SDHD genes have been commonly reported mainly in the familial cases. Surgical resection can achieve common symptom relief and biochemical remission with 15% recurrence rate. Tree-tied PET-CT with magnetic resonance imaging are highly sensitive. Gallium dotatate PET-CT identifies more lesions and shows higher sensitivity than the FDG PET-CT. These are my references, and thank you.
Thank you, Dr. Manuel. Such an interesting case, awesome images. Moving to India, Dr. Mahesh Malu will be presenting an interesting rare case of prostatic embryonal rhabdomyosarcoma.
Dr. Mahesh Malu. I have completed my MBBS from the Government Medical College, Nanded, the peripheral town of the Maharashtra location, India. The image which you are seeing mine on the title slide is I was working as a vaccination in charge officer at the Rural Health Training Center after my MBBS. Later on, as in the medical field, the role changes, responsibility changes. I am currently working as a radiology resident at Geetham Institute of Medical Sciences and Research at the coastal town of Andhra Pradesh, Visakhapatnam. My topic of presentation is regarding the interesting case of the pediatric radiological imaging, that is the prostatic embryonal rhabdomyosarcoma. Before going directly towards the interesting findings, I want to mention the special thanks to my mentor, Dr. B.K. Durga Prasad sir, and the passionate musician and extraordinary radiologist. Let's begin the case. A male child, aged 18 months, residing from the rural area of the Andhra Pradesh, has presented with chief complaint of urinary retention and a sense of pelvic mass. A suprapubic cystostomy was offered regarding the symptoms as the initial plan of the management, and it was referred for the ultrasonography examination. As you can see clearly in the image, it reveals the suprapubic cystostomy Foley's bulb in the urinary bladder, while the arrow marking towards posterior to the bladder showing mass lesion. A contrast-enhanced computed tomography axial image reveals inhomogeneously enhancing soft tissue mass lesion posterior to the urinary bladder and anterior to the rectum, as the yellow arrow describes. Apart from that, let's discuss the imaging findings in more detail across all the cut sections. So what extra we are getting through other slides is when you see in the coronal reconstruction of the image, you can see the bladder base infiltration. While you can also notice the right internal iliac lymph nodes are also enlarged. But the only doubt many of the residents who are watching this will come is how there is a clear delineation between the bladder and the rectum, and the mass lies between them. So here, a different technique was used. As you know, the famous quote by the Albert Einstein, "In the middle of adversity lies the opportunity." So here, what was used is the computed tomography was first performed initially with the rectal contrast with the feeding tube to have the plane of cleavage, and then intravenous contrast computed tomography was performed. So this lead us to the conclusion that the soft tissue lesion which we are seeing in the CT computed tomography images is in the expected location of the prostate. Study as the findings where the study revealed an inhomogeneously enhancing soft tissue mass lesion posterior to the bladder, anterior to the rectum, and the extension is from the pelvis to the level of pubic symphysis. While there is an infiltration of the bladder base, which we can clearly see in the coronal section of the images, an enlarged right internal iliac lymph node was noted. The patient was then subjected to the transrectal biopsy for the conclusion for this case. But before directly going to the conclusion, what the differentials comes to your mind? Yes, so the differential diagnosis based on the findings of the computed tomography images and the ultrasonographical findings were the lymphoma, neuroblastoma, rhabdomyosarcoma, peripheral neuroectodermal tumor, Bean's tumor, leukemia, and all other round cell tumors. So let's go to the colorful images after seeing the black and white series of images. The main finding was the typical strap cells and the rhabdomyoblast, which lead us to a conclusion. The diagnosis confirmed by the transrectal biopsy. This is a rare case of prostatic embryonal rhabdomyosarcoma. Here comes the role of the treatment. The multimodal management includes surgery, radiation, and the chemotherapy. The treatment depends on the stage and the extent of the disease and overall health of the patient. Radical prostatectomy with the pelvic lymph node dissection is the preferred surgical approach for the localized disease, and the same was applied in our case, considering the financial status, social factors, availability of the other therapies, and multiple other factors. Radiation therapy is often used as an adjuvant therapy for patients with high-risk features such as positive surgical margins or extra prostatic extension, while the chemotherapy is also an essential component of the treatment for patients with advanced or metastatic disease. So here comes the discussion and the take-home points from this case. So this was the case of rhabdomyosarcoma, but where else it occurs? Rhabdomyosarcoma occurs most commonly in the head and neck region, retroperitoneum, and in the pelvis. While in the pediatric population, the rhabdomyosarcoma is the most common soft tissue sarcoma. Overall, it accounts for 21% of the childhood rhabdomyosarcoma, but in that also 18% the majority is for the bladder, and only 3% is for the prostate, and that was my case. And the second differentiating point what we used was the use of first the rectal with the feeding tube use of the rectal contrast, and there on the IV contrast, clearly delineating both the boundaries so that we can come to a conclusion that the soft tissue lesion was from the expected location of the prostate. So it's very important for the understanding the limitations of the different imaging modalities and going a step further to use it for the benefit. Later on, as with the treatment plans and other things, the combined therapy, the overall survival rate is more than 70% with the combined therapy. So early diagnosis leads to early management and a better recovery. So these were the references I used for my case. There are no disclosure as such. I once again want to thank Children's Hospital of Philadelphia, Penn Medicine Department of Radiology, Carolyn School of Medicine for giving me such an opportunity for presenting a rare case, to present the rare case which we encountered. I thank once again from the bottom of my heart. It was a great learning experience. Thank you once again.
Thank you to Dr. Malu for this awesome case. A lot of thorough discussions and nice images. Moving to two more presentations. This presentation is from the Philippines. Dr. Marian Mendoza will be presenting a case titled "Unfortunately Perfect, a case of complete Schoen complex."
Good day, everyone. I am Mary Ancy Mendoza from Radiology Department of Philippine Heart Center, presenting to you a case entitled "Unfortunately Perfect, a case of complete Schoen complex." The diagnostic question would be, can a single modality be able to diagnose complete Schoen complex? To present the case, this is a case of a 6-year-old female born to a G1P11001 mother with good prenatal checkup and with unremarkable prenatal history. She was delivered by a cesarean section due to cord coil and with good activity and cry. She was apparently well until 3 years of age, wherein she was noted to have failure to gain weight and easy fatigability. A series of distressing cough prompted the mother to consult a physician, noting to have incidental finding of murmur of the patient. A 2D echo was requested and revealed congenital heart disease consistent with Shawn complex. There's progression of the symptom of the patient, and at 6 years of age, patient was noted to have deaf chest pain and increased work of breathing, hence brought to our emergency room. In the emergency room, the patient presented with crackles and shallow subcostal retractions with dynamic precordium and grade 3 over 6 systolic ejection murmur heard best at the right upper sternal border. Patient was admitted as a case of congenital heart disease, Shawn complex in failure. So laboratories were requested, the echo was repeated, and cardiac CT scan was ordered. The imaging revealed supravalvular membrane of mitral valve, as seen in this to the echo parasternal long axis view, pointed by the arrow. This is not seen in the cardiac CT scan. And a parachute mitral valve, wherein you can see a single papillary muscle in this to the echo parasternal long axis view, where all the chordae tendineae attached to and resembling a parachute. This was also seen in the cardiac CT scan actual view, as pointed by the yellow arrow. Coarctation of the aorta is also seen in this to the echo suprasternal view after the takeoff of the left subclavian artery, and also in this cardiac sagittal view, pointed by the yellow arrow. Note of patent ductus arteriosus is also seen. Aortic stenosis also noted in this to the echo parasternal long axis view with a subaortic membrane, pointed by the yellow arrow, and also seen in the cardiac sagittal view, wherein there is, in contrast with the to the echo, there is a hypertrophy of the interventricular septum causing the stenosis due to the extension to the left ventricular outflow tract. So Shawn complex, as described by John Shawn on 1963, is a serial cardiac defects involving the inlet and outlet of the left side of the heart. Approximately, it is around 0.6% of all congenital heart defects. It may be complete or partial, complete having all 4 defects and partial having 2 to 3 defects. So the 4 cardinal left-sided cardiac defects, as classically described by John Shawn, are the supramitral ring, parachute mitral valve, muscular or membranous subvalvular aortic stenosis, and coarctation of the aorta, which are all seen and present in our patient. The embryologic insult was believed to be a mitral valve obstruction in utero with poor development of the left ventricle and leading to outflow tract obstruction and coarctation of the aorta. Another embryological insult was incomplete division of the endocardial cushion, leading to supravalvular mitral membrane. Hemodynamic curie, wherein the accompanying shunts, abnormal vessels, subaortic stenosis leads to reduced aortic flow and hence aortic coarctation. So, in conclusion, the case presented the classic and complete lesions seen in Shawn complex. So, the key points. There's if the early diagnosis of this complex correlates to a more favorable outcome, and surgical correction remains definitive management. So our patient had a repair of her supravalvular mitral membrane, aortic stenosis, and coarctation of the aorta, and she's doing well currently, and with regular follow-up. For the diagnostic question earlier, it is hard to diagnose complete Shawn complex with only one modality. So it is best to have combined to the echo and CT scan to improve the detection of defects, not only in Shawn, but in congenital heart diseases in general. And although to the echo is readily available and cost-effective, cross-sectional imaging can provide more anatomical detail for definitive.
Thank you for the interesting case. I love the participation in the chat box. So this is our final presentation for the day. After this presentation, we will have the poll ready for you to vote for your favorite oral presentation. please make sure that you would vote and ask your friends to join. We're up to 270 participants. Thanks everyone for joining. I know it's getting late in some parts of the world, so let's move forward to Dr. Roberto Munoz from Chile, talking to us about IgG4 related prostatitis mimicking PIRADS 5 lesion.
Hello everyone, my name is Roberto Munoz, a second-year resident from Santiago, Chile. I have nothing to disclose, and I'm going to present the following clinical case entitled IgG4 related prostatitis mimicking a PIRADS 5 lesion. The case involves a 47 years old male patient who presents with a 2-month history of obstructive urinary symptoms. His PSA levels are 0.28, and the rectal examination reveals a diffuse induration of the prostate. Due to these findings, it was decided to complement the study with a multiparametric MRI. First, we have a slight increase in prostate volume, low PSA density, and as you can see, the prostate MRI shows extensive infiltrative involvement with diffuse low signal and loss of differentiation between the transitional and peripheral zones on T2 images. This lesion shows mild restriction on diffusion weighted sequence and progressive enhancement on dynamic gadolinium enhanced sequence. And this is just for discussion, is this a typical prostatic adenocarcinoma, considering these factors, the patient, young age, low PSA levels, and an atypical lesion showing diffuse involvement of the prostate with low T2 signal and loss of differentiation between anatomical zones? It raises questions about whether this represents a typical adenocarcinoma or not. Then let's consider some differential diagnosis. Could this correspond to an acute prostatitis? The images and the patient age support this. However, the absence of fever, pain, and the low PSA levels make us consider another diagnosis. Then, could it be another type of prostatitis, for example, granulomatous or autoimmune prostatitis? The images, patient age, absence of fever and pain, along with low PSA levels support this. However, the absence of a compatible medical history, such as treated bladder cancer with intravesical immunotherapy, steers us away from this possibility. Finally, could it be an undifferentiated carcinoma? If so, in this case, the patient history will support this diagnosis. And I repeat, this was just a discussion. This was reported as PIRADS 5, and the patient underwent biopsy. The biopsy results show extensive lymphocytic infiltration and elevated IgG4 levels without evidence of neoplasia. Subsequently, a PET-CT scan with FDG was requested to evaluate involvement of other organs. In this PET-CT scan, we can observe diffuse hypermetabolism of the prostate, as well as hypermetabolic mediastinal and iliac lymphadenopathies, along with involvement of the left orbit. This was complemented with an MRI of the orbit, which shows exophthalmos thickening and enhancement of the left lateral and inferior rectus muscles, as well as the optic nerve sheath. The laboratory test confirmed the diagnosis with elevated serum level of IgG and IgG4. The patient started treatment with oral corticosteroids, and his symptoms resolved within 48 hours. These are the follow-up CT images taken 1 month after treatment, showing a reduction in volume and enhancement in both the prostate and the mediastinal and iliac lymph nodes. Then, what findings could have helped us? And this was a retrospective analysis. On the MRI, the diffuse involvement with loss of anatomical differentiation on the prostate gland or the low values of PSA density. On the PET-CT, the diffuse hypermetabolism of the gland and or involvement of other organs. And in the CT scan, the resolution of imaginary abnormalities with the use of corticosteroids. All of the findings together should expand our differential diagnosis and could help us reach the correct diagnosis. And to conclude, some key points to take home: this is a rare condition, but evaluation with different imaging techniques can lead to the correct diagnosis. It generally correlates with low levels of PSA, and his clinical presentation often resembles benign prostatic hyperplasia that typically respond quickly to corticosteroid therapy. Thank you very much.
Well, this concludes our presentations for today. Now we will have our judges vote for the presentations, and we will also pull up the poll for you to vote for your favorite one. By now you should be able to see the poll, and please go ahead and vote for your favorite case. This will determine the People's Choice Award. Feel free to vote, and I hope you enjoyed this educational session. We will be back in around 10 minutes with the results.
Here. Hello. Okay. So we are ready to announce the winners. We have, oh, I see. Okay, we're gonna start with the People's Choice Award. Again, this is just based on your on the answers that we received from that poll at the end of the session, and the clear winner on that was Dr. Lakshmi Malia with a case of crop typhus epidemic at its worst. And so a case from India, that's a People's Choice Award, and congratulations.
Congratulations.
Right? Now, we had an unusual situation where the judges had, there was a tie for the second place. So what we're gonna have is a winner, a first place winner, 2 second place winners, and then in this iteration, we don't have a third place. All right, for the second place, the first winner is Joe Rizkala. Oh, from Lebanon, with imaging features of hepatic pecoma. Yeah. So congratulations, Joe.
Congratulations, Dr. Rizkala.
And then the second place, the other second place, is Emmanuel Carlos Limas with a case of Berry syndrome. Again, congratulations. That was a great case. And without too much delay, our first place winner is going to be Elsa Wartono with from Indonesia with an awesome case. It was a challenging case of congenital bronchoabdominal fistula. Congratulations again to these 4 winners. As we celebrate, we thank the support from the Global Health Center from the University of Pennsylvania. We thank our partners in Penn Radiology and the rest of the team at the Children's Hospital of Philadelphia that make it possible. Thank you all for participating. We have 270 some people joining in live to look at to see the cases with us. We appreciate your participation. This year or this iteration, we had the most submissions ever. We had 130 cases submitted. So again, just to say that the celebrations are in order for those winners that are the best cases among well over 100 cases from all over the world. So take a moment to celebrate yourself, and we'll be in touch. A reminder to please use this QR code to vote for the posters. There were so many good cases that we couldn't accommodate for this live session, so we put them here in the poster session. They will have separate awards, so please vote for them, and we'll see you next time. Thank you all.
Thank you, Dr. Hansel, for all the support. And thanks for everyone who made this this competition a success. I just want to remind you to please access this QR code to be able to vote for your favorite posters. And we will be in touch with you over the coming week for more details about the award and when will it be announced. Thank you so much. Do not forget to vote and share with your friends, and we will be in touch. The link is also posted in the chat box.
Thank you, guys.
Thank you. Thank you.